Eccoci qui, siamo live. È un grandissimo piacere per me oggi introdurre il lavoro di Cristina Ganz. Cristina Ganz, I'm speaking in Italian.
Sì.
I'm so sorry. It was so natural. Since Cristina is in Italian and we've been talking together in Italian, it escaped completely my mind. Nevertheless, let's switch to English. So it's a great pleasure for me to introduce Cristina Ganz today. She's currently a PhD candidate in philosophy of language and epistemology at Vita Salute San Raffaele University in Milan. Her research interests include feminist philosophy, gender studies, and gender medicine. Her doctoral project focuses on perinatal violence, with particular attention to the communicative dynamics between perinatal care professionals and pregnant, parturient, and postpartum individuals. The aim of her work is to identify communication strategies that enhance the effectiveness of perinatal care by reducing misunderstandings, addressing epistemic and affective injustice, and fostering trust. So we are extremely lucky today to have Cristina with us tackling topics that are so important, specifically the title of her presentation will be on perinatal consent. And we are Nobumpnocare, a platform that connect people to support individuals during their reproductive journey. Cristina, thanks again for being here. The floor is all yours.
Thank you so much, Susie, also for selecting my paper, my abstract for this beautiful webinar series. I am very honored to be here today. And you can see something?
Yes.
Okay, perfect. Today I will present a part of my PhD research, which is informed consent in prenatal care. And I'm a little bit anxious because it's the first time that I'm presenting this specific part. Indeed, as Susie said, my PhD research is focused on prenatal violence, in particular on a specific type of perinatal violence, which is defined in literature as non-consent care. And I think that in order to better understand how non-consent care is perpetrated, can be useful to think about informed consent as a performative act. And furthermore, can be also useful to look at the epistemic and discursive wrongs of non-consent care. So today I will try to do that, so to analyze non-consent care from linguistic and also epistemically point of view. And at the end of the presentation, I will also discuss a proposal to improve informed consent in perinatal care. So in doing so, I will use some data that I have collected with Mara Floris and Nomi Paciscopi, two colleagues, through 4 focus groups with Italian midwives, which we audio record and transcribe and then analyze with thematic analysis. And of course, we had their consent to do that. And I will also use an egalitarian language, so I will use the term pregnant, laboring, and postpartum women in order, people, in order to recognize the existence of trans men and non-binary people in prenatal discourse and the violence that they have to face. So I think that we can start by seeing a definition of perinatal violence, which is commonly called obstetric violence. And this is a definition provided by 2 Italian activists, Sasha Damiani and Francesco Salviato. I just changed some terms in order to make the definition more inclusive. So they define prenatal violence as an intentional or unintentional appropriation of the bodies of those gestating, laboring, and postpartum, along with their reproductive capacities by various perinatal care professionals, leading to several psychological and physical consequences. So it's a very generical definition, and I also insert in this slide one of the most famous categorization of the perinatal violence, which was created by Bohren et al. But today I will not use this categorization, even if it is very useful, in my opinion, to better understand what perinatal violence is. I will use this other categorization offered by Castro and Frias that studied the Mexican setting. And they distinguish obstetric and abuse from non-consent care. And today I will talk about non-consent care. I think that we need to speak a little bit about informed consent in order to talk about non-consent care. And when we talk about informed consent, there are different models. One of the most known is the implicit or explicit model of informed consent. And we can see that there are two different phases. The first one is when the healthcare providers disclosure to us the information and give us some recommendation. And in this first phase, we have only to understand them. But in the second phase, we can make a decision and give an authorization that can be implicit or explicit. It is implicit, for example, when we roll up our sleeves in order to get vaccinated. But the most common one is the implicit form. But there is also another model, which is the opt-out consent. And it is very similar to the previous one, but in this case, our consent is given for granted. So we have to disapprove, to not authorize the healthcare practice. And there is also another form, which is the presumed consent, which requires also surrogate decision maker. But this kind of consent can be justified only in 4 conditions: when our health is at imminent risk and we are temporarily unable to give consent, or when we are unable to provide informed consent, even if our health is not at imminent risk. And then there is the so-called therapeutic privilege, which allow doctors to withhold all or some relevant information because they are afraid that the disclosure of that information can cause harm to us. But this kind of privilege can be used only in specific situations. And then there is another condition, which happens when we decide to delegate our decision-making to another person. So I think that it can be quite obvious that in order to give our informed consent, we have to be competent and also free in our decision-making. But when we talk about competence, I think that we should understood them, it not as only the ability to understand what we are authorizing, but also that we are authorizing. So we should think about informed consent as a performative act because it has the power to change the social reality, because we can turn, for example, an act from an assault into something permissible. When I talk about performative act, I'm referring to the Austin theory of speech. And he said that it is possible to analyze a speech act through 3 different perspectives. The first one is the locutionary perspective, so we can analyze if utterance is well formed or not. But there is also a locutionary perspective, so we can analyze the action carried out through the utterance. And then there is the perlocutionary point of view, so we can look at the effects and the consequences produced with our utterance. Today I will focus on the locutionary point of view, and according to Austin, there are 5 different actions that we can carry out with a speech act, and informed consent is all of them, because with an informed consent we are exercising a right, and in doing so we are also committing ourselves to a specific course of action. Our informed consent is part of communicative exchange because it follows the disclosure of information. So with informed consent, we are also giving a verdict on whether those risks and benefits are acceptable for us or not. And we are also exposing our position. Our decision also depends on our emotional states. So with our informed consent, we are also expressing behavioral attitude. According to Austin, some illocutionary acts can be corrected and withdrawn, and consent is one of them, and it is also recognized as a human right. But as I said before, our consent follow disclosure of information, and also the latter can be understood as a performative act. Indeed, the healthcare personnel is exercising the power to provide us the information. They can decide how to expose the information, and they are also committing themselves to a specific course of action, which is enact our decision. In order to successfully perform a speech act, according to Austin, we have to follow some felicity conditions, which is basically to follow conventional procedures. And in the case of informed consent, the conventional procedure is defined by the national law. There are a lot of national law about informed consent, but almost of them said that healthcare provider must provide clear and adequate information within sufficient time. They have to collect explicit consent and act with the right intention and also respect the outcome. On the other hand, the patient must has the capacity to understand and give voluntary consent and also respect the outcome. So when one of these felicity conditions is not respected, we can talk about non-consent care. In perinatal care, I think that it is possible to distinguish three different types of non-consent care. The first one is the absence of valid consent. Then there is the denial of consent, revocation, and revision. And at the end, we can also see the manipulated or withheld information. So I think that we can start with the first case, which can occur in two different scenarios. When our consent is not solicited because presumed, and when we expressed our will, but it is ignored. So in order to better understand the first scenario, I think that we can see a legal case, which is also an illustrative example. It is a legal case happened in Portugal, where a woman was subjected to episiotomy without her consent. And she later suffered from several consequences, and she was convinced that the consequences were due to the episiotomy. So she sued the hospital, and the Supreme Court ruled that the consent was not necessary because episiotomy was considered a routine practice that can be urgently required. As we can see in this case, the perinatal care providers did not collect the explicit consent. So it is a case where the felicity conditions are not followed. And this is not a single case. It is a tendency to not solicit the consent, as the study of Valente et al. Show. Women in Italy do not give consent for Kristallin maneuver, episiotomy, or instrumental vaginal births. There is also the tendency to justify the fact that the consent is not solicited in perinatal care settings. And there are different types of justification. The first one is that the labor is often considered an emergency where the decisions are time critical, but a study of Wolf and Charles showed that several routine interventions are performed without informed consent before any real emergency occurs. Then there is also the idea that pregnant people are incompetent because the labor's emotion impaired the rational decision making. But said that not all individuals experience labor in the same way, and even if labor is painful or stressful, there are methods to manage this kind of emotions. And she also said that in other medical contexts involving fear and pain, patients are still considered capable of providing consent. So the same thing should happen in perinatal care. And then there is a ultimate justification, which is the belief that pregnant people are willing to accept any physical or emotional risk for the benefit of the fetuses. Kingham observed that in pregnancy, the pregnant person undergoes medical intervention to benefit another person. And there are also other two situations when happens something similar, which are the human subject research and organ donation. But in these two cases, the informed consent procedures are more stringent, while this is not happening in pregnancy. So according to these three counter-arguments, the presumed consent in prenatal care should not be justifiable. I think that we can also look at the epistemic wrongs of an unsolicited consent, and I think that it can be analyzed as a form of preventive testimonial injustice, because the pregnant person testimony is not requested because of a presumed lack of relevance and expertise of the pregnant person. The other scenario that I mentioned was when our will is expressed, but at the same time ignored. And there is another legal case that I think can be an illustrative example, which happened in Czech Republic. In this case, a woman arrived in a hospital in active labor, and she was asked to sign a very long informed consent, but she was unable to concentrate, so she asked for a verbal explanation, which was denied. So she refused to sign. And during the labor, multiple procedures were performed without her consent, even if she objected to all of them. She then sued the hospital, but the court ruled in favor of the latter, justifying the intervention in the name of the fetal health. Also, in this case, the felicity conditions are not respected, because the prenatal care providers did not respect the decision of the pregnant person. We found a lot of evidence also in our focus group. For example, in this testimony, one of the midwives tells us that she often do not listen to women, for example, when they ask for a cesarean section. And here there is another example where another midwife tells us that she didn't listen to a woman who required an epidural. In these two cases, the midwives think that it is correct not to follow the will expressed by the pregnant people because they must adhere to the evidence-based guidelines. But Pickles sustains that evidence-based guidelines can be applied in a way that silence some pregnant people's needs and desires as it happens. So also in this case, we cannot justify the fact that someone ignored our will. If you look at the epistemic and discursive wrongs, we can understand the ignoring the express will as a form of perlocutionary silencing, because in both the cases that we have seen, the pregnant person successfully perform a locutionary act. Indeed, they clearly express their will, and they do that with a perlocutionary intention, which is that the perinatal care personnel act accordingly to their wishes. And the prenatal care professional understand perfectly the illocutionary act and the intention, but they prevent them from occurring. So in this case, it is a case of perlocutionary silencing. But it's also a form of testimonial quieting, because perinatal care professionals assume the pregnant person lacks decision-making competence and therefore dismiss their expressed will as unreliable and uninformed, favoring their medical knowledge. So the second type of non-consent care was the denial of consent, revocation, and revision. Again, here there is another legal case happened in Italy. This is the story of a woman who desired a vaginal birth after a cesarean section, which is something that we can ask. And she was hospitalized for monitoring, and she was asked to sign a consent form for cesarean section, just in case. But after signing, she was told the operating room was ready and the cesarean section would proceed. Again, in this case, she wasn't able to revocate her consent, even if it is a right. So again, the felicity conditions are not respected, and we can understand this, conceptualize this kind of denying of revocation as a form of perlocutionary silencing. That is the kind of injustice that we already seen. So the last form of non-consent care is manipulated or withheld information. In the previous legal case, the woman decided to sue the hospital, sustaining that the consent was obtained under misleading premises, and she was totally right. But the court dismissed her claim, sustaining that there was not any kind of violation of her right. Again, the felicity conditions are not respected because she was not completely informed about the future operation. There is a tendency to withhold information, as the study of Valente et al. Demonstrate. Women do not receive complete information from Cristelle maneuver, episiotomy, and instrumental vaginal births. We found a lot of evidence also in our focus group. For example, here a midwife recognized this tendency to withhold the information or exaggerated them in order to get the pregnant person to make the decision based on what the provider wants. And they often do that by, for example, evoking fear on the baby health. This is another example of a woman who had an emergency C-section, and during this operation, she had her uterus removed, but she didn't know about that. She just discovered it later when she decided to understand why she wasn't able to have another pregnancy and why her body was so much changed. And I think that it is important to highlight it that the woman in question was a Black woman, and she was inside the reception camps. Of course, it is a case of extreme withholding information, but I think that it is one of the worst examples that we found. We can understand these kind of examples as a form of testimonial void, which happens when a speaker withholds, distorts, or manipulates information based on an unfounded assumption or biases about the hearer's capacity to understand or use it. But we can also see that there is an effective wrongs in this case. Indeed, with the intention of distorting or withholding information, perinatal care professional may exploit pregnant person emotions, for example, by invoking fear around the possible risks to the fetus, as we see. So how we can improve consent care in perinatal care? Well, there is a proposal of Van der Peel et al. They talk in this paper about episiotomies, and they try to understand how to improve consent in this specific kind of treatment. And they suggest to implement individualized approach, to use the antenatal period to exchange information and explore values and preferences. And they also talk about using opt-out consent when a pregnant person does not give a conclusive response during labor and the stakes are high. And they also suggest to strengthen trust. And I think that the second proposal is fundamental to improve informed consent in prenatal care, but there are a lot of evidence in the literature about how in doctor-patient communication, misunderstanding, epistemic and affective injustice can arise. So I think that we need to think how to avoid this kind of phenomena. And so I think that these two codebooks that me, Monica Consolani, Mara Floris, and Nomi Paciscopi develop can be useful in that sense. These are two codebooks that we developed by analyzing 32 transcripts of conversation between the patients with pancreatic ductal adenocarcinoma and their physicians. The first one aimed to detect misunderstanding, while the second one, the HEAL codebook, aimed to detect epistemic and affective injustice. But if we look, for example, to the categories individualized in the Tutan codebook, we can also find some tips to avoid misunderstandings and not only to detect them. For example, we as professionals, which I'm not, we can avoid the technical jargon. We should avoid terms which have different meanings in everyday language and in medical context, and we should respond directly to the patient's questions without being evasive. We also should implement the Christian maxim. So the suggestion is to provide all the necessary information without withholding them. We should share only evidence-based information and only the relevant to the patient decisions. So we should not overwhelming them. And of course, we should communicate in a clear way. Also in the HEAL codebook, we can find some tips in order to avoid epistemic and affective injustice. For example, we should acknowledge patients' emotions and provide space for them without distracting, neglecting, dismissing, or eliciting these feelings. And we should also avoid to reinforce our own authority and on the other hand, diminishing patients' knowledge. Instead, we should encourage patient to share their personal experiences. I think that these tips can also be helpful in prenatal care setting and help to strengthen the effectiveness of communication with the pregnant person and furthermore also to implement in informed consent. But of course, we should also validate these two codebooks in prenatal discourse by collecting conversation with pregnant people and prenatal care professionals. We are working on it, but it's a little bit difficult to enter in this kind of settings, but cross fingers. And thank you for your attention.
Wow, Cristina. I don't know from where to start. I mean, the examples that you brought are appalling. So I have one question that verges around the examples. Do you think that the instance of the woman whose womb was removed and she didn't know, do you think that was a human error in not communicating and so on? Or do you think that it was, do you know, because it's not about thinking, as far as you know about that case, or was there a procedure that keeps the woman as ignorant as possible about what's going on?
Well, I don't know for sure because when the midwives tell us this story, they were pretty calm about it, while me and my colleagues were absolutely shocked about it. And
you should.
yeah, but I think that even if there is like an emergency, you should talk with the woman. I think that she wasn't able to talk in Italian, but there are, of course, people that can help you to speak with someone foreign.
Right.
And I also know that there are a lot of another example like that in literature of Black women in reception camps that have undergone the same things. So I am afraid that this is a way to control their reproductive right, because there is the idea that they should not be able to have more pregnancy, that they do not deserve this kind of experience. I think that this is something like that, a form of obstetric racism, I think. Yeah.
Oh, signora. Oh, that goes even farther than I thought.
Yeah, but I'm very negative about that. Maybe it's just a human error. I
No, because if you know, I mean, without if you know, as you know, in the US too, it's a big problem, systemic racism in perinatal care. The death, the rate of deaths after birth and during birth is higher for African American women mostly.
I was thinking about some evidence in USA. There is a beautiful book called Uterus, and there is the history of this group of women that was undergo the same thing. So I was just thinking about
yeah. It's sad that even if we move the historical context, because of course the US has a different history than Italy, we find the same results.
Yeah,
it's horrible. And this was one example, but the other the episiotomy is. I have no words because it's something that at this point we should have overcome, and we're still there. It's something that should belong to past generations.
I totally agree. And because I also, with my PhD, I'm doing some period with an association of midwives, and they organize also some perinatal courses. I don't know how to say it in English. I don't know if there is a
makes sense. Classes in perinatal. Yeah.
And I remember this woman who asked about episiotomies because she was from America Latina, and here there is a lot of problem with perinatal violence. So she was totally afraid about episiotomies, and the other woman in the room weren't aware about what episiotomy was. And the person who led the course just said that in Italy is something that we do not anymore, but it is not true. There are data that show us that it is a tendency. I think that we should talk more openly with women about that, with pregnant person in general about that, to make them in the position to decide, to know what is happening.
Because it leaves the woman invalid. I mean, of course, in most cases, the tissue can heal. But it's an invalidating procedure that often is done for the benefit of the medical personnel. And as you were rightly pointing out, women's voices are not listened to because, okay, they are in pain, they are hormonal, they are just yelling. And in the US, for example, but not only in the US, as far as I know, it's spreading. There's the natal plan, the birth plan that the women can deliver before the birth, which is a fantastic idea. It goes toward the individualized approach that you were presenting, with which I completely agree. But it's very easily dismissed, not just because of the emergencies, but because lets us work.
Yeah.
give us space to work.
Yeah, also here it's the same thing, and I also heard about some midwives that they are very surprised about the fact that this kind of plan are very similar, despite the fact that maybe the women is different. And but I think that it's pretty normal because a lot of women desire a respectful birth.
Treatment.
So yeah.
Completely. What do you think about the application, the resources of the application of this individualized approach? I mean, an individualized way of communicating, because here we're focused on language.
Well, I think that we should also go to continuity of assistance. And if we don't have this kind of continuity, we cannot have this kind of individualized approach, in my opinion, because if the healthcare personnel change continually, it is impossible to also have a very relationship of trust.
That's so very true.
Yeah.
Yeah, and the resources are becoming slimmer and slimmer. We are trying to technologize healthcare because in this way we can spare money, and you cannot establish a relationship with a bot or with AI. I don't know if you just, there was a news, a terrible news here in California a few days ago of a kid, 14 years old or something, who suicided after long conversations with ChatGPT, who suggested how to do it, how to hide traces.
Yeah, there is a tendency to rely on technologies, and another midwives tell us that a lot of women ask if they have contractions because they also rely on monitoring. And it is crazy, but they do that because everyone do that during pregnancy. They do a lot of exams, and most of them are also not evidence-based. For example, the estimation of fetal growth is totally unscientific, and even if it's used,
a must.
Yeah.
Yeah. It's a thank you for working on this essential problem. Yeah, we should go in the direction of establishing relationships.
Yeah.
And a relationship takes time, trust, continuity, and this costs money, especially in a society where professionalization is based on not being yourself. You know, to be a professional, you need to be a kind of an impersonal being that treats everyone equally and does always the same things and so on. So we are going completely in the other direction in the way in which we treat professionalism. A bit at a time.
Yeah.
Slowly. I mean, I see good tendencies here with the way in which they blend the technology and healthcare with diet programs, because obesity here it's a problem. And so they created this app that is connected to a human being. You meet with a human being every 3 weeks, a long time. Over the time, you establish a relationship. Who knows if we'll manage to create more consistent in perinatal care as well.
We have to stay positive.
Yes, exactly. We need to think of solutions and not only look at the problems. I really like the way in which you presented your paper, because you did an amazing job at presenting all the problems and gave a piece of solution, which is what we always need.
Thank you so much.
Thank you, Cristina. It was truly a pleasure to have you. I don't see any question from the live chat. Yeah, have a good rest. I mean, today, two conferences,
Yeah,
two
thank
presentations
you.
in one day. So
Yeah.
enjoy your rest and your weekend.
Thank you. Thank you so much for having me and for organizing this beautiful seminar. So
It was
thank
all my
you.
pleasure.